Welcome to the Clinical Consultation Network. As you can see, I am not Dr. Davis, but I am filling in. I'm Michelle Bagby. I'm the Coordinator of Behavioral Mental Health Services for DIDD. And I'm happy to introduce Shannon Westerman, who will be our main presenter for the day. She's also joined by some of the interdisciplinary team for East Tennessee Homes from the East region of DIDD. So Shannon, if you want to introduce yourself, tell us what you do, how you got into the field, and an interesting fact. We will launch in with that.
Okay, I am Shannon Westerman. How I got into the field, maybe I'll make that my interesting fact. How about that?
That's great.
When I was in grad school, I had a professor that came to me and said he had somebody that wanted some work done with their child. The child was diagnosed with autistic spectrum disorder. And they had to manage to, in the school system, get up to 40 hours a week of therapy with the child, doing discrete trial learning. And so he was 3 years old, and I started doing work with him. Worked with him for a few years, but out of that, because I'd started work with him, my professor got me an internship with the state in DIDD. So once I finished my internship, I got a graduate assistantship and then started with the state full time. The interesting thing, I guess, about that young man is all of the intervention did him such good that, I left after about a couple of years, but he had made so much progress that 15 years later, I had him in one of my psychology classes. I teach part-time, and he was sitting in the front row of one of my psych classes. And it was just such a great experience to kind of move forward like that 15 years later.
Yeah, full circle.
Early intervention is truly key for some kids.
Yeah, so you want to talk a little bit about what you do within the department? I know you have many facets of what you do within DIDD.
Sure. I work with East Tennessee Homes as the behavior provider. I also work within the regional office doing forensic work, and also I assist on the RPRT, Regional Psychiatric Review Team. So, and whatever else is needed at different times, I think.
Absolutely. All right, so do you want to go ahead and share your presentation on your end and tell us who you have joining you today from East Tennessee Homes team?
Absolutely. You tell me if you can can you see it?
We can.
Great.
Start the slideshow.
Yep.
There you go.
Got it. Great. So this is an interdisciplinary approach to cataract surgery. This comes from, I guess, over a decade of work that I've done with interdisciplinary teams, helping to support people who need cataract surgery. So I think that I have a host of people from East Tennessee Homes on the line with me. I have our Assistant Director of Nursing, Pam Wagner. I hope I have several case managers. We have Tony Cox, Penny Hughes, Christy Mathis, Josh McNabb, and Alice Nichols, and they serve an integral part of trying to organize this. Our dietitian, Rhonda McNabb, Director of ETH, Margie Story, our Director of Nursing, Stephanie Britton, our Director of Program Operations, Holly Bernard, our Director of Psychiatric Services, and also our East Tennessee Regional Medical Director, Dr. Victor Schuler, our Director of Residential Services, Kima Wells, our Event Management Coordinator, Christina Weems, our Occupational Therapist, Timothy Lee, our Physical Therapist, Tina Vital, and our Speech Language Pathologist, Peggy Garland.
That is an impressive lineup.
It is a huge list of people. They are all very important in this process. So as we go through, if anybody has any questions, please feel free to jump in. So I will go ahead and get started if that's okay with you, Michelle.
Absolutely.
Okay. So this is an area that has come up over the last, in the departments where I've worked over the last 15 years or so. We have folks who are diagnosed with cataracts, and this is a clouding of the lens that progresses over time. They can cause a lot of blurry vision and some distortion of the perception of color. And if you don't have surgery for it, eventually you will likely lose your vision. Some of the statistics I found that said over half the people over the age of 80 have been diagnosed with cataracts. And for most of us, you're diagnosed with cataracts You say, okay, I'm going to schedule surgery, not a big deal. And you can see again pretty well after you have the cataract surgery. But we found within the population that we serve, some of the research shows that they can develop cataracts at an earlier age and that the incidence might be much higher among those diagnosed with intellectual disability. And there's a variety of reasons for that, but I did find a picture that kind of shows our progression of cataracts over time. And so for us, we can start, for those of us that are able to communicate pretty accurately, we might say, you know, things are starting to get a little cloudy. As I'm getting older, I have a little bit more difficulty reading, and so I can complain about that and tell what the symptoms are and request different glasses. But for the people that we support, oftentimes, we don't know that their vision is significantly changing without the regular eye exams, and even that can be pretty difficult. So when we are working with people diagnosed with intellectual and developmental disabilities, sometimes we have to look at the behavior that we're seeing rather than just depend on somebody's verbal experience. So some of the major symptoms that I have looked for is some increased incidence of falls, difficulty assisting oneself with meals. So for instance, if somebody typically has been able to eat pretty proficiently and they're maybe missing the food or kind of missing the plate, difficulty reaching for objects such as a glass that's in front of you, reporting of visual experiences that sometimes people might interpret as symptoms of psychosis. I had somebody once that was reporting that it looked like it was snowing outside and had behavior reports written up that the person was seeing things. And we kind of looked at some of the diagnoses and thought, well, it's a possibility that maybe they're seeing things, but it's also a possibility that that is their interpretation of what's happening with the cataract surgery. And then difficulty seeing at night, which again, you might see with an increased incidence of falls or looking confused as well. So we look at the role of the interdisciplinary team, and I have been very fortunate in working in ICF facilities to have large teams to help support this process. And primarily at the very center of our interdisciplinary team is the person that we support. And hopefully that they are able to report symptoms, either verbally or non-verbally, of some of the visual disturbances that we have. Now, the majority of the people that I have supported have not been able to verbalize the difficulties that they have, but I have had some that will accurately say, I'm not seeing as well, and I would like to have cataract surgery. So once all of the procedures have been explained to that person, hopefully they can provide consent to the procedure. But oftentimes the people that we support, at least in the facilities where I have worked, are not able to provide consent. But we do want to make sure that we hear their concerns, get their opinions, and obviously their assent to the procedures. The next most important people that are in this process are our direct support professional staff, because they're the ones that are going to see the changes in functioning on a daily basis. So if I go into a home or I'm working with somebody, it's often just for small snippets of time. It is your direct support professionals that are going to see the changes over time, that are going to see the small things and hopefully document that so that those of us who are kind of checking out the documentation or writing reports can find where the issues lie. They also are assisting with the medical appointments, and during the surgery and after the surgery, they're providing the most important part, which is the direct care for the person that is having the surgery. With our case management, they're responsible for coordinating the services, communicating the options to the person supported and to the conservators, trying to coordinate care with the healthcare providers. This is a huge monumental task, even though it doesn't sound like it is a monumental task at times, trying to get all the pieces, even with our person that is responsible for event reporting and HRC, because in our ICF system, we have to make sure that we have certain things in place and there are certain policies and rules that we have to take care of that maybe aren't in the waiver world. Our agency administration, this is seriously important too, because the people that we support, we have to make sure that when we prepare for cataract surgery, we're really prepared for it. And this includes ensuring adequate staffing and our materials materials that are available for the people we are supporting. I always say that when we're planning for cataract surgery, we kind of plan for every contingency. It's almost like planning for battle, because not with the person, but with the system that you have to have. You have to have every department involved. With our nursing, obviously they assist with scheduling, obtaining the necessary orders, providing treatment prior to and after procedures. Also making sure that we're very clear on what the recommendations are for pre-op and for post-op, and trying to prepare the individuals for that. And over the years, some of the recommendations for post-op care has changed, and sometimes person to person that it changes. So our nursing is really valuable in making sure we get that information. Our physical therapist is very important because they can assess changes in positioning that is required for post-op. So I have had some people that are supported throughout the day in various positioning devices for the purposes of, let's say, digestion, or for the purposes of trying to make sure that their posture is correct, or for a variety of reasons. And we have to consider if those are positions that we can modify for a period of time, what is the best way to modify those positions. We also have to make sure that we educate the person supported, the circle of support, and the conservator, if there is a conservator, on risks associated with ambulation without surgery. I have worked with some people as their cataracts have progressed, they have more and more difficulties with walking. And so, especially for people that we as a group decide that surgery may not be the best option, we have to kind of prepare for that. What's that going to look like? What are we going to have to prepare for? Is it going to be assistance for that individual, maybe hands-on assistance? Or is the person eventually going to have to rely on things like a wheelchair or ambulating around their environment? So this is a really key thing, and especially as our physical therapist monitors that person over time, she's going to see some of the increases in things like falls, some of the changes in how the person is walking. Our speech language pathologist, for some of the people that we support, we have used post-operative medications for healing. So especially if the person that we have has difficulty with swallowing, our SLP is going to be important for helping us to assess if the medications are going to put that person at risk. So do we think that the individual might have more and more problems? Are they at risk of choking? And if so, what are some of the options that we have? Assisting with communication devices. So if we have somebody who can communicate using switches or communicate using cards or books, our SLP helps us to facilitate that communication with the individual. And also hopefully making sure that everybody is well trained with respect to the person's communication style. All of the folks, I believe, right, Peggy, that we have communication plans that tell what it's like if the person seems to be in pain, or if the person is happy, or if the person needs assistance. Our dietitian also can help with assisting the nutritional needs during our post-operative recovery if a change in diet might be necessary. And I've also oftentimes turned to our dietitian if we need to look for edible reinforcers if desensitization is attempted. And I'll talk about that in a little bit. But we find that sometimes those reinforcers, as we try and shape behaviors, are very important. But I have to make sure that I'm not doing something that's really inconsistent with what their diet needs are. We have occupational therapists, and if sensory issues are present, we look to our OTs for possible interventions to help decrease discomfort or distress. They can also help with finding some appropriate splints if necessary, and again, I'll talk about that in a few minutes, but also with finding sensory objects to help with relaxation and redirection. And this can be really important because during that post-operative time, you want somebody to be really relaxed, and you don't want to have a lot of stressors on them, but you also don't want them so bored that that's what they're focusing on as well. Our primary care provider in psychiatry, this is where we look at consultation for appropriate medications for post-operative recovery. So if we think somebody, if we determine that the risk is worth trying cataract surgery with the person, with the conservator. Sometimes we need to be prepared for something like medications to help keep the person as calm and relaxed as possible. And so one thing that we look towards is the records, what has been tried in the past. And you can get this from their psychiatric records, even from their dental records in the past, because we find a lot of people have used medications to assist with dental treatments. And especially because this can be a difficult time as one loses their vision because of the cataracts, but also because of the stressors of the surgery. We want to make sure that we've considered the individual psychiatric conditions that the person has had. So Dr. Schuler will often work with us related to that. The behavioral and mental health services, what I have done in the past is help to assess the tolerance of the skills necessary to complete postoperative surgery. So when a person has cataract surgery, we have to make sure that they can do things like wearing goggles, wearing a patch, tolerating eye drops. So I have looked at and developed and implemented desensitization plans in the past, have assisted in planning for possible challenging behaviors during the postoperative healing process, and also looking for reinforcers and preferences that can be used, not just for the desensitization period time, but also for the healing recovery time, where we do want a lot of things to help keep the person calm. And also, yes.
On the desensitization, you're doing that prior to the surgery, where you're evaluating how well they tolerate some of those things and eye patches and whatnot that they may have to do afterwards, correct?
Right. And I'm going to talk in a few minutes about some of the experiences that we have had in getting people ready using desensitization.
Okay, great.
Okay. Our ophthalmologist, we need to make sure, if we can, that we have a provider with some experience working with people who have intellectual disabilities. I have been to some eye exams with people that are extremely challenging. And because I don't like having eye exams where they puff the air into your eye, but when you have somebody who has lots of sensory issues or doesn't understand the process, it helps when you have somebody who has some experience and determining if their visual problems are neurologic or if there's true visual problem. And I found a quote on here from INET magazine that says, if someone has acquired cognitive impairment, it can be difficult to assess their vision. It's a challenge if the patient can't cooperate with testing. And that part kind of stuck out to me again, because I have been with some people where the doctor sat like 6 feet away and all they could do was sort of shine a light from a distance. So it becomes really important for them to at least have some experience. Some of the research that I looked at even said if you have pediatric ophthalmologists, that they sometimes have different behavioral interventions that they can use, like holding up different items that are interesting just to see if they can follow the visual field or their objects moving back and forth. So that kind of covers the realm of people that we typically interact with on our interdisciplinary team. Some of the major issues that we have to look at when we're considering a person for cataract surgery is, one, the desire of somebody to see again and enjoy their normal activities. I have worked with people that have been in their 90s, and after the team kind of reflected and thought about the risks and the benefits, didn't really feel like, along with their conservator, that it was worth the risk, and that they really had a desire to see it better, I guess. We also, in the absence of the ability for somebody to provide input, it's really critical for our conservators to have informed decision-making abilities where they know the risks. I've worked with some conservators in the past because we've had other issues along with cataracts that they said, you know, normally I wouldn't consider this, but because of this other issue, we really have to do the surgery. And again, looking at the age of the person. Historical reactions to medications is also really important. I have known some people who have responded very poorly to some of the anesthesia that they have used. I shared with my supervisor that one time I was assisting somebody coming back from cataract surgery, and they had such a poor response. I said, if we get pulled over for anything, they're going to think we're kidnapping, just because the person was really agitated. And we were having to really block to make sure that that person's eye was safe. Psychiatric conditions that can worsen as a result of the cataract. So if you have somebody that suffers from depression, losing that vision is going to obviously make things a little bit worse for that individual. So we have to consider that as one of the issues. Behavioral issues that can worsen as a result of cataracts or could interfere with a successful cataract surgery. Because if you have somebody that actively maybe hits their head or rubs their face, you have to be very conscious of that because of the risk associated with the surgery. And while it's generally considered a very safe surgery, some of the things that you have to worry about are infection, inflammation. Retinal detachment is one of the issues that you have to be very fearful of. Lens fragments can end up being in the eye. And that is one thing that you're going to have difficulty if the person doesn't communicate as well, reporting back about that. Fluid built up. Dislocated lens is another one that you have to be cautious about. And that's why you really have to be careful about somebody hitting themselves or rubbing that eye. Bleeding and then high eye pressure is another problem. So we look at post-operative recovery. It's really critical that we prepare for this part. If a person can't tolerate some of the post-operative care, some of the consequences could be pretty significant. So we always, as we start this process, we really want to plan and try to plan for as many contingencies as possible. And one of the things, of course, right now during our COVID-19 pandemic, it's been really hard because you have to consider things like staffing. At any given moment, you know, somebody could test positive and be out. So what's going to happen? And we have attempted cataract surgery during this period as well, but it just requires more and more planning. So some of the major issues that we have looked at for post-operative recovery, starting at the very basics, is people who have a fear of medical offices or facilities. I worked with a lady one time, just going towards a doctor's office caused her to become very, very agitated. And we spent 6 months just getting her used to going near that facility. Tolerance of eye patch or goggles. So some people don't like to wear glasses or patches or goggles. That can be a huge factor. Tolerance of eye drops. And as I have found with some people, it's one thing to tolerate eye drops that are just like saline drops, but it is also a whole different thing to tolerate eye drops that sting afterwards because you have the natural desire to rub your eye, which leads to also prevention of touching your eye. And this requires things like supervision. You've got to be able to block medications for post-operative recovery, and also considering things like soft splints to prevent touching of the eye. Once you kind of commit to this process, you need to consider every part of this along the way to prevent injury. Movement following recovery is also important. Some of the recommendations say you want to be able to avoid bending over for 1 day, but you also have to avoid some vigorous or strenuous exercise for a period of time. And then obviously infection control. You know, can the person tolerate taking a shower without getting their head wet? Will they tolerate taking a bath? Also, don't allow their hands or their eye drop bottle near their eye. So all of these, even though it doesn't sound like a lot, the planning takes lots of consideration along the way. I'm going to talk about a little bit more about each of these in depth.
Shannon, how long is the average recovery period?
Usually about a week or 2 weeks. So the eye drops can last longer, but what we plan for is at least a week for some of these more significant post-operative interventions. And then it's always directed by the provider for how much longer they may want some of these things to continue on.
And in your experience, have you ever had a situation where stereotypy had to be a consideration for some of those strenuous or vigorous movements that you want to avoid post-operative?
Yeah,
In the post-operative period?
Things that we have considered kind of go back to some of our OT interventions. You know, are there some things that we can use to keep the person more occupied, to decrease some of the stereotypical behaviors? And if it has been too significant in the past, that is one of the things that we have to consider with our risks versus the benefits of having the surgery.
Sure.
So fear of medical personnel or medical facilities. I think a lot of us have, even in the last 6 months with COVID, we've maybe even developed a little bit more paranoia associated with going to medical facilities. But it's important to think about desensitization, and this can even help with procedures later on. So a person that I worked with one time, like I mentioned, had some significant fear about going into even medical offices. And fortunately, it was in an area where we could kind of visit a couple of times a week. What we would do is we just started gradual exposure. We would play music. She had this favorite CD that was, I even, when she moved to a different home, made sure they had copies of this CD to take with her. But this music that really relaxed her. And we just gradually started exposing her to that medical area so that she could get used to it and not try to, get out as fast as she could. And it took about 5 to 6 months before she was even comfortable being around some people wearing the white coats or seeing the medical equipment without becoming super stressed out. Now, that was just getting used to the medical facility. We had to get used to all of the other stuff as well. So remember that when you're considering cataract surgery, that it's not always a quick process, and you have to determine at the front end, and again, this comes with your supervisory staff, if you have the time and energy to commit to preparation, because if you can't, then some of the outcomes can be pretty dreadful. The next thing that we look at is the tolerance of the eye patch or goggles. So typically when we have somebody that is considering cataract surgery, I'll just go in and ask them, can we try this eye patch on you, or can we try goggles on you, just to see if it bothers them at all. And it's important for us to consider different options. I've even gone into our local ophthalmologist office, and they give me different kinds of eye patches and try different kinds of tape that we can use. I had one person that just flat out refused to wear goggles until we dug into my son's Nerf war collection that had all these different colored goggles, and the pink ones were what really turned the tide, and she decided that she could wear goggles if they were pink. So you have to kind of think outside of the box as well as to what some people might want or what they were willing to use. And while tape, if you've ever had tape on your face, it can be very irritating, and it leaves that stickiness there that people have a tendency to rub. So if the goggles are something that the person will tolerate better, you can work with your surgeon to see if that is an acceptable option for them. Now, most of the time they'll want them to, well, all of the time, they'll want them to wear that patch home. But afterwards, they typically recommend that you wear the patch at least at night. But if we have somebody that really does well with the goggles, that can oftentimes be worked out individually. And we find it's best for the person to wear the goggles or the patch for at least the first week. Now, if it was me, they'd probably just say you can not have that on during the day, but because there's always that risk of touching your face, you want that extra barrier there if the person will tolerate it. So if we find somebody that does not tolerate those, then what I've worked on is tolerance programs where we maybe started out where somebody would wear the goggles for 1 minute and really work on reinforcing that minute. And then along with staff, we've done it on a daily basis, and then we come in and do weekly observations or assist with it as well, is make sure that we try to build the amount of time. And what I have found in my experience is if somebody can wear it 45 minutes to an hour without touching it, then that's kind of the acceptable level, because we can make sure that we keep that protected for that amount of time, and they'll typically wear it all day if they're willing to wear it for that amount of time. We have had some people that just plain old can't tolerate the goggles. And at that point, if tolerance of the eye patch or goggles is not an issue, or is still an issue, and we need to make sure that this is the path that we wanted to go on, then we have to consider other options, which I'll talk about in a few minutes. Tolerating the eye drops is also another significant issue. We want to look at the person's history of eye drops. A lot of people have had them for a variety of reasons over the years. We have considered tolerance program with lubricating eye drops, and a lot of times our nursing staff will help facilitate getting a prescription for eye drops so that we can work on trying them on a daily basis. And you want to really reinforce this. And our SLP has helped us with social stories or videos to kind of help explain the purpose of eye drops, with the explanation that eye drops may sting after surgery, so that they're aware. You want to make sure that somebody has full informed consent about doing this. And also within the context of that social story, discussing not touching our eye. And these can be books that you can do, or they can be videos that you could do to show the person so that they begin to see the purpose of it. Some tips that we have had for success with eye drops: make sure that we have some really highly preferred activities available. If you have somebody that really likes YouTube videos or looking at kittens, make sure that you can have something to show them immediately afterwards, that you stop it and then maybe start it again as soon as the eye drops are done. Really engage that person in some upbeat conversation. You don't want to start out with saying, "I'm sorry, but this is going to sting," because oftentimes that sets them up to want to push the person away. Make sure we tell them what we're going to do and really reinforce successful tolerance of the eye drops. And especially after surgery, you want to make sure you have somebody available that can kind of block, because again, there's that natural tendency, it's reflexive to want to touch your eye. And we have to prevent touching of the eye or trying to wipe that fluid away. So oftentimes we make sure that they have a tissue to wipe excess fluid. So preventing touching of the eye, if the eye drops, tolerance of the eye drops fail and tolerance of the eye patch fails or is not as successful as you want, at that point you have to consider, again, are the risks worth the benefit of having the cataract surgery? And again, all of this you have to consider with their ambulation, their quality of life. So if we have somebody that we're especially concerned about with touching the eye, we look at this post-operative recovery period, and we find that supervision is extremely important during this time period. We have to have somebody oftentimes within arm's reach, or at least within line of sight for several periods or several days. We've had some people that we're not at all concerned about. We really think they're going to tolerate it, but we always try to make sure that we have available staff, because you don't know for certain how somebody's going to react afterwards. And you need to make sure that they're able to block any attempts at touching of the eye. And because it can cause some pretty extreme agitation, sometimes we have to consider medications for post-operative recovery. Also, some soft pillow-like splints that can be used to prevent the arm to bend. So they just look like pillows, and you kind of put it around the arm so that it prevents them being able to touch their eye. Now, in our ICF facility, we do have to make sure that we have HRC and consent from the conservator for that. And there's also very specific requirements for documentation, because they are considered restrictive. So we have to consider the person's reaction to interventions like this. And again, at this point, determine if it's worth it or not. Movement following the surgery. There's oftentimes some very specific recommendations that for movement. In some situations, they may request that you not sleep on the same side of the surgery. And we've had some people, and you're thinking, well, that's the side we sleep on. We have to be careful. So considering other alternative sleeping arrangements, like can they sleep in a recliner, or could we use a positioning device that they really enjoy? All of these are things that we have to think about, and making sure that the person doesn't bend over. Maybe there's somebody that reaches over and touches the floor all the time, or there's somebody that likes to run everywhere that they go, and you have to be cautious to avoid the strenuous activity. We also have to, again, make sure that we have assistance by staff to make sure that we try to maintain posture as much as possible and provide activities to help keep the person relaxed. We had somebody one time who was in a wheelchair and had the tendency to kind of bend over quite a bit, and our physical therapist helped us with straps that would help keep the person in a good supportive position, because she had to have the cataract surgery for other reasons beyond just the cataracts. Infection control is also especially important to make sure that the risk for infection is minimized. Not everybody likes baths. Some people really like showers, but are they willing to get in the shower without the water running over their head? So some things that we have considered are things like the dry shampoos. Are they willing to take a bath and just have the dry shampoo done? Or is it something that we can go for a couple of days and not have a shower every day? What is important for that person to have for their daily hygiene? And how still can the person be for eye drops? So Michelle mentioned some of the stereotypical behaviors. If you have somebody that is constantly rocking, it can be extremely difficult for them to stop and put their head back. and the tip of the bottle not touch the eye. So these are things that we have considered in the past with our occupational therapist, of things like using vibrating mats or holding vibrating objects, so things that can help provide some of the input that maybe they need to help calm themselves over a period of time. And then we look at when some of the interventions stop. This is, again, something that we kind of have to be prepared for. I typically say a week, but we also prepare for at least a couple of weeks because you don't know exactly how long the provider wants the person to maintain those lifestyle changes. The eye drops have to continue for a period of time. And so if we need additional staffing, we're very lucky here that we've had very supportive supervisory staff to make sure that we have the additional staff that we need. So some other things that we have to consider beyond just the post-op care, for the one-to-one staffing following surgery, sometimes this is really necessary. If you have other people that are supported in the home, you need one person that is really dedicated to this individual that has had surgery. It can be flexible depending on the needs of the person, but you also have to make sure that the staff person is very familiar with them and their activities, their style of communication, because they're going to be the one that can report to us, hey, I think there's something really, really unusual going on. We had a case some time back where we made sure that we had one-to-one staffing following surgery. And for whatever reason, whether it was complications with the anesthesia or with the eye drops, the person ended up having some pretty major problems afterwards. And if it hadn't been for the one-to-one staffing being there and available, we're not certain what the outcome would have been because they noticed something was going on immediately and they could call for assistance immediately. You also, when you go for surgery and for the medical appointments, I always try to recommend that we at least have 2 staff. Sometimes we've taken 3 staff because you have somebody that's obviously driving them to and back from the appointment, but you have to have somebody that is available to block because you don't know how somebody is going to come out of the anesthesia, even if it's somebody that you're not at all concerned about. A lot of times we have to be concerned that the reaction may be a little bit different. So it may be necessary to kind of block during transportation back. And then training all of the staff in the home, including nursing, as well as any staff who could be pulled into the home during the post-operative time period. And that can be a pretty lengthy process if you're trying to make sure everybody's on the same page for the cataract surgery. And you want to make sure that it is people who are comfortable implementing whatever procedures that you have. Typically, when we have somebody with cataract surgery, we end up just writing some general instructions that kind of dictate what to do at this point, and this point, so that it's written down. They have something that they can refer to because a lot of our staff are bombarded with training from lots of different areas. And you want people that are very comfortable with implementing any procedures that you have. So what we hope to occur if we've made the decision to have cataract surgery, we want to make sure that that we followed kind of all of the plans that we have and be prepared for any contingencies that may occur afterwards. We had somebody at one time who had the cataract surgery and then ended up having to go into the hospital within days of having the surgery. You have to make sure that you're communicating, hey, this person has eye drops that they have to have. We realize they're having a different issue, but we just had cataract surgery, so please make sure you do this. And especially during the times of COVID, you have to say, we've got to make sure that we have staff that can stay in there with them because we can't let that eye get touched for at least so many days afterwards. And what we hope we see for a person is improved vision. I was with somebody one time, our primary care provider helped take the patch off after they had cataract surgery. It was just like this beautiful moment because we made sure she was outside and could be around flowers. And for her to be able to see where she previously couldn't see, she smiled and you could tell that she was affected by the surgery in a positive way, although she wasn't able to verbalize that. We also hope that we see a better quality of life for the person that is supported. They don't need as much support maybe during eating. They're able to walk a little better, or they have fewer injuries. And this goes along with our increased safety that we hopefully see for the individual. And if they're able to tolerate, if they're able to tolerate the surgery the first time, then we oftentimes have to consider the second eye, because it oftentimes happens in pairs. You don't want to do both at the same time. And I know many, many years ago, I have seen one person that had both done at the same time, and it's really kind of dangerous to consider doing that, because I have seen or had some discussion with folks who have seen cataract surgery not go well. If you don't take the proper precautions, and the person can end up with a much worse quality of life after they lose their vision. So this is a kind of a picture before cataract surgery and after cataract surgery, the difference that it can make for the person supported.
Yeah, I just wanted to share, my mother had cataract surgery, and she described the difference with being able to verbalize it as looking through the bottom of a Coke bottle, like the old glass Coke bottles. And then after surgery, she said it was like looking at an HD TV. So it can be a pretty dramatic difference depending on how severe the cataracts are.
It really can. I have worked with some people that cataract surgery was not this one particular case that I had, cataract surgery was an option for only one eye, because I don't know, pretend to know all the technical terms, but all the little parts in there that would hold a lens in the other eye it wasn't going to work. So we had to make sure that if we felt like doing the cataract surgery on the good eye was worth it, that we had to take it really seriously, because any damage to that one and she would be completely blind almost immediately, where at that point she still had some vision. And it's a pretty weighty decision to have to make for somebody else. Obviously, it's the conservator's final call, but the circle of support oftentimes has a pretty big influence on what the conservator will decide. And it's a huge decision for somebody else. And so you have to kind of put yourself in the shoes of the person that you're supporting, and what would you like, and what risks do you think they would want to tolerate. And for some, surgery is just not an option. For some, it is just far too risky. And I have worked with some that are like that. If it's not an option, at that point, our circle of support has to prepare for the physical and emotional impact of worsening vision over time. We have to be concerned about, is this going to cause depression? Is it going to cause confusion? How are we going to interpret some of the challenging behaviors that we might see? Is it because it's a physical issue, or is it because they are reacting to that? We also, over time, in my experience, we have worked with folks who have mobility specialists. They can help orient the person around. Our physical therapists have worked with us on safe ways to ambulate, to work as their vision declines. So this is a whole other process, and it's long-term planning if surgery is not an option for the people that we are supporting.
I would imagine there's environmental modifiers, their vision worsens to make the home environment safe.
Yeah. So a lot of things you have to consider is making sure that things don't move around the home, that once something's organized, you can't have somebody that likes to rearrange the furniture all the time. You have to make sure that you have cues, or sometimes even handrails around, so that the person can have something to touch and to orient. And you want to spend a lot of time helping the person orient to that environment that they're going to be in. Obviously, there's some devices that people can have, like sticks that they can use to help ambulate if they're used to using those, or can learn to use those. But you also may have to consider things like wheelchairs for people when they're going out into the public, where they don't necessarily always have that same environment all of the time to safely get around. So that can be a huge consideration. And then these are just a couple of the references that I found that discusses some of the issues that you may have. So we'll kind of stop there. I wanted to see if I have anybody from East Tennessee Homes that has information to kind of add to this process that I didn't cover. Quiet.
Don't forget to unmute yourself.
Or if there's any questions.
And we don't have any questions in the chat box, so you can unmute yourself to ask a question if you have any, or you can enter them in the chat box and I can read them to Shannon. Like we've got somebody.
It's Tina.
Hey, Tina.
I'm a physical therapist from East Tennessee Homes, and I just wanted to reiterate what she said about expect the unexpected with the medications. So my little mother had a stent put in about 3 weeks ago, and after she woke up in recovery, she was climbing out of the bed. You know, you have to lay still and hallucinating, and for like 6 hours, it was just really impossible. So you never know how someone will react to the medications. And that's why doing the history, because sometimes people have had similar medications before, is really important.
Yeah, how someone reacts to anesthesia can always be a surprise. You know, they can be very impulsive and uncharacteristic behavior. So I definitely applaud, you know, reemphasizing that component. Looks like we have a comment, which is thank you for the insightful presentation. It's encouraging to learn how in tune the department is to this issue. The possibilities for improved quality of life and independence are beautiful, as well as how to anticipate and care for the people supported when surgery is not an option. So just a thank you, not a question.
Well, and it really, I have been so fortunate. Most of the people that are on our team I've worked with for many, many years. And it's just, it is a huge team effort when you're doing procedures like this. And you find that it kind of crosses over to other procedures that somebody might have to face as well.
I was thinking that as you were going through it. I mean, you guys have really nailed down the holistic approach to this and how to plan and how to consider every area that it's going to impact potentially. And I think, you know, that structure and that format can give people guidance for other more, you know, medical procedures that may have a recovery period or how to look at planning something like this for an individual with IDD. So I think, you know, even if you don't have that amazing interdisciplinary team at your disposal, how to communicate with other service providers within the circle of support to try to plan and prepare for these types of things that are, you know, inevitable to all of us. So I really applaud the approach you guys are using. We did have one question. Have you used similar approaches to tolerating dialysis?
I have not. I've never worked with anybody that has required dialysis, but I do think that we would consider the exact same approaches. What is the person supported? We have had people in the past who suddenly went from things like being able to eat to not being able to eat, and have to approach that from a team effort as well. What can we do to help them mentally and physically prepare for those changes? And again, some of the same issues. How do we deal with the post-operative recovery period? And then all of the paperwork and associated with all that can be kind of a little bit daunting, especially within the ICF system. So if somebody has to have something, and this is just within our system, has to have splints, there's specific ICF guidelines for, down to how long can they wear them, and you have to monitor every 30 minutes, things like the color of the skin, the circulation look good, do you have to take it off for so many minutes during a 2-hour period? So even the documentation can be pretty intensive.
Yeah, and I think it's you guys are considering, you know, how this impacts the person emotionally. I mean, a lot of people, you know, maybe the planning and the preparation for how everything's going to work and how to keep the person safe and have a good recovery period. That piece is you know, kind of intuitive, but you know, to think about how the person may be impacted emotionally, whether it's in preparation for the procedure, after the procedure, how it's going to impact them if they don't have this procedure. I think that component's really important to look at. We had another question. Do you guys have any suggestions, or do you use the same kind of prep and procedure for someone who's receiving hearing aids?
Again, I have not had anybody that had hearing aids, but I think we would probably proceed from the same route. You know, you'd have to consider, that's a kind of a strange experience having something in your ear. So I think you'd have to assess what is their tolerance to different things. And I would even start with things like earphones. You know, how well does somebody tolerate that? And try and work up before you spend thousands of dollars on something that, even my own grandfather, he hated his hearing aids, and he would like throw them down. I'm not wearing these. So it can be really challenging, and you would want to make sure that you assessed that ability ahead of time.
Yeah,
Yeah.
frequency changes and volume adjustments with hearing aids, that can all, especially for someone who has sensory issues, that can all be a pretty impactful experience. So
Yes.
want to consult your team on that as well. Any other questions or comments? I don't see any more at this time, but I want to make sure everybody has a chance if they're typing furiously to get them in.
Well, this is Peggy. I'm a speech pathologist, and one lady, we used her iPad, and there's a software called Go Talk Now, and we made boards for her that talked about what it was. One was what it was going to be like to prepare her to have the cataract surgery, and then after the cataract surgery, what she needed to do, what was going to happen. And the staff would read that to her. And as time went on, she didn't want to hear it anymore. But I think it was good that she did have that to just it was constantly informing her what was going to take place, give her more information.
Yeah, priming the person for what to expect. I think that's a great aspect to make sure that you hit, especially, if someone has more difficulty understanding, situations and changes like that, or difficulty with transitions. All of that preparation is very important.
Yeah. And for the person with the hearing aid, they sell things at Radio Shack, or they used to, where it's an amplifier. And if you try that on the person first and see if they feel any benefit from being able to hear, try it several different times, that might be a good indication whether they would want to even have a hearing aid.
Absolutely. All right. Well, it looks like that's all of our questions for now. I really appreciate Shannon and the rest of the East Tennessee Homes Interdisciplinary team coming on and sharing this insightful information. I think it definitely gives people a lot of good insight into how to prepare and plan for these types of situations that are inevitable for all of us, but especially some considerations to make for individuals with intellectual and developmental disabilities. So thank you again. And thank everyone else for joining us. We'll be back again next week. Dr. Davis should be back next week at 12:30 Central Time on Tuesday. So we hope you can join us and enjoy the rest of your evening.
Thank you, Michelle.